few days here, they're very elevated mood, grandiose, delusions, hyperactive, they don't have need to sleep, their ideas are all over the place. Begins suddenly, escalates over several days. Then they're going to hit their depression part. So they've had their manic, now they're going into depression. So no interest in anything they usually got pleasure in, negative views, fatigue, no appetite, constipation, the libido's down, suicide preoccupation, agitated or have movement retardation. So this is second only to major depression as cause of worldwide disability. There we go. Onset could be late teens, 20s, or even 30s. So again, some of the symptoms, you see how they interact there, panic attacks, so the hopelessness, again, depression, irritability, fatigue. So they do interact with each other as they're switching from manic to depression. So here's a picture. This is a normal brain, and this is what a bipolar brain looks like. So they tend to have more of the gray matter reduction that is involved in self-control, the orange on this picture here. The sensory and visual regions. So when she talks about schizophrenia, you will also see difference in the brain images when they have schizophrenia. So it's kind of interesting to see that it actually does change in their pictures. So again, manic, here we go. Dig fast is a way to remember that. Distractibility, indiscretion, grandiosity, flight of ideas, activities increase, sleep deficit, and they talk a lot. I've got some different other memes like this. I'll open those up for you too today. Sometimes those help. Some people like to use it. Again, some more symptoms. Symptoms there on your. So different ones, again, talkativeness, activity. So this is just showing you again what you might see. Have you seen any bipolar in mental health clinic so far that is showing any of this? Yeah. Yes? Okay.
Rocky, get down.
Experience with a person in particular from work where they've cycled in and out of going back to the hospital, trying to readjust their meds because they're aging and their body is failing them too, so it can get hard as they age.
Right. Good. Yeah, so you will see these. So what do we do for these?
Come here.
So let's show you this. So this is another movie. You can that you can do a extra credit on.
I'd like double cheeseburger, fries, and chocolate chip. Just kidding. So, close my account, please.
Okay, you have $12,752 there. Do you want that 100?
Oh, it's 137. One step back. Here's what we're gonna do. We're gonna fly down, come around the front of the ambulance, go around the back, and land right on the bed. Oh, yo, come on back here now.
According to the police and hospital reports, you have been disrupted and very disturbed.
I have a big personality. I'm grandiose. This is a problem. I'm a kid, all right? I promise I'll be a good boy. Talk to me.
Cannot see you. If you do, I will turn you in. This is not about protecting myself. This is about him, the patient. Richard Gere. Oh, Mr. Jones.
So that's a very good movie to watch. Has anybody seen it? Very good. So you can watch that and use it for your extra credit. But he goes from the manic to the depression. Richard Gere is a very good actor. Okay. Oops. Oh.
We are going on a family vacation.
There we go. Okay. Interventions. So what do we do? Again, safety, right? For the client and others, because when they're in that manic, they're going to get in other people's space. So they may have to keep them in the rooms on the psyche, to keep them from not invading other people that doesn't want people around. And again, we assess for suicidal ideation. Psychological needs, we want to decrease that environmental stimulation, right? Calming environment. Make sure they're getting the right nutrition. Again, the therapeutic communication. So we want clear, simple sentences. Have them read them back to you. They're having these flight of ideas. They're doing this, they're going to do that, they're going to do this. We want to bring them down to one thing. Appropriate behaviors, so risky behaviors. He met the girl at the bank, took her out, and if you watch the rest of the movie, you'll see the rest of that. Clothing choices, you want to treat them with dignity. So, their clothing may not be appropriate for wherever they're at, so you need to make sure they understand that. Managing medications, lab levels for lithium, we haven't talked about that yet, we will here. Make sure their water intake's good. Teaching, family and patient. They're not going to listen that the risky behaviors are dangerous. He's up on that roof, out there on the edge. To him, he's feeling like he can fly. So education can help reduce that guilt and that shame when they realize what they've done. Treatment is psychopharmacology. This is a lifetime regimen. Can prevent acute cycles of the bipolar behavior. So we want to stop them from cycling back and forth, manic depression. Anticonvulsant agents can be used as mood stabilizers. And then we'll talk about the psychotherapy. Okay, so lithium, that's your main one here. So it is contained in your body in the salt. It can cross the blood-brain barrier, placenta. This medication is effective in 75% of people. They're in your in the levels is 0.8 to 1.5. So anything greater than 1.5 is considered toxicity. So how do we treat the toxicity? They may do gastric lavage to get it out of their system, correction of the fluid and electrolyte balance, and dialysis for that kidney function. If it's greater than 3, their organs are going to come into play. They're going to start having organ failure or shutdown. So here's our anticonvulsants that we may use instead of lithium. So these are they proved helpful in stabilizing the moods of people with bipolar. So they may use the lithium and these. So you have the Tegretol, Depakote. You see some of these for seizures, right? For Neurontin. We see that for other things. So now you're going to see them using them for these also. Topamax, they use that for headaches, right? So they may use a combination of these with the lithium to help. Now the bad thing is we're going to run into some medication problems with this. Neuroplastic malignant syndrome. So any of the antipsychotic meds can cause this. Main treatment for this is by stopping the medication. EPS is a reversible movement induced by the neuroleptic medication. And again, this can go away with our medication adjustment. Dystonic reactions. This is like a pseudo-Parkinson looking, where they're spazzy, could be painful. Tardive dyskinesia is also late appearing. So there is a scale it talks about in your book, abnormal involuntary movement scale. So on that scale, it decides, are they having this kind of reaction? What are they going to treat it? Okay, so that's bipolar. Now we're going to start some cognitive disorders. Cognition is a mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. So when they're having a disorder, they're not having these, right? So the different types we're going to look at is delirium, dementia, and amnesthetic disorders. These disorders are a group that involves loss of memories, loss of ability to create new memories, or loss of ability to learn new information. Okay, our first one is delirium. So this is a syndrome involving disturbance of consciousness with change in cognition. Usually from an identifiable psychological, metabolic, or cerebral disturbance, or a disease from a drug, or from drug intoxication or withdrawal. Elderly patients is in the majority, usually after surgery in the hospital. Have you heard of ICU psychosis? Have you took care of anybody with that?
I had a patient last week in clinical who had hospital-induced psychosis
Okay.
on med-surg.
Okay, it can happen on med-surg. You're going to see it a lot in ICU. My brother-in-law, after they had surgery, he swore the mafia was there. He could tell us what they looked like, everything. And I think still to this day, he still thinks it really happened, But it was like psychosis of his ICU. We're going to talk a little bit about DTs here in a minute. So any stay in a hospital, especially if they're from a nursing home or they've started having sundowners, you're going to start seeing problems with that. So treatment of delirium, again, you're going to treat the underlying cause. Is it a head injury? Is it trauma? Is it drug withdrawal? A lot of time we're going to sedate them. Ativan, Haldol, sometimes we'll hold the Ativan for drug withdrawal because the meds may worsen the symptoms. And then other things, of course, they need their hydration, they need the nutrition food. We only restrain when necessary. Years ago, we even used leather restraints on the floor. They quit that many years ago, but we used to be able to do that on the floor when we had a patient that needed it. So our nursing process for this is acute confusion, right? Risk for injury, again, we want to make sure they're safe. Increase orientation and reality. So manage their confusion, give them orienting cues, where are you, what is the day? Low, clear voice, avoid that sensory overload. Again, promote sleep, nutrition. Years ago in the rooms, we used to have a mirror right above the sink, right across from their beds. A lot of times we had to cover that with a sheet or a towel because they thought that person in the mirror was somebody else coming after them. So you'll see that a lot with these. I know where you work, summer, you're seeing that probably. Okay, the big thing, I can't remember who I had in the summer. We had a guy that was going into this. She might be in 2030. I don't remember who it was. So delirium tremors, DTs. They affect people who are heavy drinkers and they've had a head injury or they had to stop it. Our guy in the summer had pancreatitis and he was starting into these the day we had him. Risk factors, of course, is alcohol, previous brain injury. They're going to treat him with phenobarbital, fluoxetine, diazepam, so it just kind of depends. Let's see if I had the... Okay, the CWA. How many of you have done the CWA during clinicals? Yeah. Okay, I got that coming up here. I think it's next. Yeah, so there's the CWA. So if you have a patient starting into this, this is how they decide what we're doing with them. So blood pressure, they get a point for that. Tactical disturbances, it goes up to 7. Auditory, it can go, they can be as high as 7. Visual, or they have some hallucination or delusion. So all these together decide how often they're checked, when the Ativan is given. If they're bad enough, they need to go to one-on-one, a sitter, or even ICU. So it just kind of depends what's going on. Has anybody done those yet at clinical?
Not yet.
Okay. I don't know that you will in the mental health unit, but you may on the cardiac. So clinical, institute, withdrawal assessment, alcohol. So usually it is alcohol. You will see them go into DTs. Okay. Dementia. So this is a progressive cognitive impairment. They can have aphasia. What's aphasia, Katie? You know what aphasia is?
Is it difficulty with speech? Is that what it is?
Right. They know what they want to say, but it comes out it's not that. You'll see these with stroke victims. How about apraxia?
Difficulty moving or like walking.
Okay. Impedability for motor functions. Even small ones like tying their shoe. They can't tie their shoe. They can't button their shirt. Agnosia. Who knows what that is?
Is that loss of smell? Or
No?
thinking?
It's actually recognizing or naming objects, person, or sound. So they may not recognize a person, or they may hear a car horn and not realize what it is. And then executive functioning is just can they think and plan? Can they initiate? Or can they stop something? So that is parts of dementia. Alzheimer's disease, of course, you have all heard of that. This is gradual, increasing decline. They usually die not from the disease, but from aspiration pneumonia or something similar, nutritional, they quit eating, whatever, pneumonia. Head trauma, again, it depends on the location of the brain injury. Huntington's disease, this is inherited. I've had a couple cousins with this. They just move continuously and they die young too, usually in their 30s. Again, it's with their pneumonia. Parkinson's is tremors, cognitive. Prion. Have you ever heard of prion? It's caused by the prion, which is a type of protein. It usually triggers normal proteins. This triggers normal proteins to fold abnormally. So the proteins you have, it's triggering it to do something wrong. This is what the mad cow disease, if you've heard of that, this is an example. Pics is a degenerative. Vascular dementia could be onset. And then we have our others, our HIV can also get dementia. Okay, so what are we going to do for these people? Treatment and progress. So, again, the underlying cause, we may have to change their diet. Are they exercising, control their high blood pressure, their diabetes? Their physical and mental abilities. Replacement therapy, you've heard of Aricept. Behaviors, the doses are 1/2 to 2/3 lower than usually prescribed. Antidepressants can cause delirium already in these people. So a lot of times they'll use the SSRIs because they have fewer side effects. Antipsychotics, again, is Haldol, Seroquel. These are to help manage the psychotic symptoms, delusions, hallucinations, or paranoia. And then again, mood stabilizers like lithium, Tegretol, and Depakote. That's to help them from having their outbursts and give them a little bit of energy. So what is our intervention again? Safety first, always protect themselves from injury. Psychological, each client, is a unique person. They have their own personal strengths. Emotional support, we want to make sure they have that. Interactions with family, familiar surroundings for environment. Reminiscent therapy, take them back to what they knew. I read a story once. The guy used to have a horse, so they got him a saddle, and he would just polish his saddle, and that helped him with his cognition. So, give them time away from what they're doing, distract them. So these you can get confused really easy. So here's a little graph to show you the difference. So delirium is acute onset, can be treated. Altered state of consciousness. Depression is gradual onset, can be treated. Look for signs such as low self-esteem. Dementia is also gradual, might be treated. They're going to have a bigger memory loss and a decline in cognitive function. self-awareness issues, inability to teach a patient with dementia, you may feel frustrated or hopeless, because you can't get through to them. Know that there is progressive deterioration with no hope for improvement usually. So importance of dignity for the patient and the family. Okay, let me show you that. Here is another video if you want to watch it. It's a very good movie. I think it's on Amazon Prime. That's called Still Alice. Very good movie, or a book if you'd rather read a book. But for your extra credit, you need to. Okay, so there was 2 case studies on your modules. If you guys seen them, I'm going to split you into 2 groups, and I'll tell you which case study you can work on. We're going to do about half an hour unless you get done before then we'll come all back together and go over the answers. Okay. So let's do